All right, next up we've got Meredith Borland from Perth in Australia. She's an emergency, paediatric emergency doctor and is the head of paediatric emergency at Perth Children's Hospital. Thank you.
Thank you, Sarah, and thank you, Damien, for inviting me to come along and introduce a little bit more information about PREDICT, which is the Paediatric Research in Emergency Departments International Collaborative. We're international because, as a research network, we're Australia and New Zealand, and so we're international. One of the things you have probably already worked out by hearing Stuart talk is that we love acronyms. So I'll try and explain any acronyms I use as we go along, and I apologise if I skip over any and people feel a little bit sort of uncertain about what we're going to do. So I'm going to talk about how we evolved and where we're going with the research in our network to try and address some of the issues that Stuart has provocatively put up there for us. Okay, so this is a motley crew back in 2004 of paediatric emergency physicians that were interested in doing research in a randomised controlled fashion in our emergency departments, come from all states of Australia and New Zealand. And we managed to get together and form a little network and decided that we would set ourselves goals. We looked a lot at PCAN and PERC and tried to sort of determine how we were going to run ourselves. And we recognised that we needed, as a group, to develop some infrastructure so that we as a motley crew could be organised and coordinated so that we could run research across our departments while we were still all active clinicians. We also wanted to produce and publish randomised controlled studies that were being undertaken in multi-centre fashion. To do that, we needed to work out how to get money out of people, anyone who would give us money, but particularly large grants that would allow us to employ research staff. And we wanted to grow. We wanted to grow beyond our tertiary emergency departments and large mixed departments into the smaller departments that Stuart sort of described, where most of the children who come for emergency care actually present. So this is our foundation sites in 2004 covered a fairly good range of the bigger cities in Australia and New Zealand. So we're pretty happy that we had fairly good representation. And we started on the path of doing our large studies. Firstly, we undertook basic epidemiology projects. We needed to understand what we all did. We didn't actually really know whether I did it differently to New Zealand or Queensland or whatever. So we undertook a study retrospectively of all our management of common paediatric emergency presentations. And that included a fairly large retrospective study on the convulsive epilepsy, the more serious end of convulsive status epilepsy review, which helped us with our future planning with studies. So out of those basic epidemiology studies, we actually showed that one area where there was actually divergent management was where we were giving hydration to children who presented to our departments with bronchiolitis. And Stuart has mentioned that that's a commonest reason for children coming to the emergency departments, particularly at this time of year in Australia and New Zealand, not in UK. So the study we undertook was known as CRIB, Comparative Rehydration in Bronchiolitis. It was a study that was undertaken in 7 of our sites, and we randomised children to receive nasogastric hydration versus IV hydration as their first therapy if they needed non-oral rehydration. We undertook that study over 3 years. It was published in Lancet Respiratory in 2013. And the take-home messages from that study was that IV and nasogastric were both appropriate therapies, that nasogastric insertion actually required fewer attempts than IV attempts in small children, And so the study really supported that there could be an increased use of nasogastric hydration in previously healthy infants with bronchiolitis. What it also did was, for our network, it actually gave us research staff for the first time. We had people that we were paying to being part of collecting of data, and we actually recognised the benefit of having research staff. It demonstrated to us as a network and also to other people looking in that it was feasible for us to run a multi-centre study across a vast country and countries and get reasonable results. So it gave us a lot of kudos. And then the outcomes from that study helped to inform us with applying for and being successful in receiving a 5-year NHMRC Centre of Research Excellence grant in 2013, which actually then gave us infrastructure money to coordinate the network. Our next big study we undertook was the Australasian Paediatric Head Injury Study, known as AFIRST. So AFIRST was a study that we undertook. It's prospective observational study, and we were determining we were looking at the clinical decision rules that have been published previously from PECAN, CATCH and Chalice. So CATCH is the Canadian rule, PECAN is the American rule, and the Chalice was the first rule that came out, which came from the UK. And we were determining when we should or shouldn't do a CT scan in children who are presenting with head injury. Large study, we enrolled over 22,000 patients into that study, and we were determining which was the best of those clinical decision rules. We generated so much data in that study. It's pretty exciting. We still are using that data to help inform a lot of papers that we're publishing. The primary paper was the accuracy of the clinical decision rules, and that was published in The Lancet in 2017. And what we demonstrated from our collection of data was that all of those clinical decision rules were actually highly sensitive at picking up which children actually had traumatic brain injuries and which ones didn't. The regions with high CT rates certainly should incorporate clinical decision rules into their decision making, because it will reduce your CT rate, which is something that we want to do in children who don't need it. However, regions like ourselves with low CT rates may actually run the risk that we could, by incorporating these rules, in fact increase our CT rates in children. And so there's obviously an area where any adoption of a rule needs people in that region to actually understand what your local CT rate is and how good your clinicians are. And that may vary from a tertiary hospital to a regional rural hospital, maybe possibly not having the same confidence in their clinicians' accuracy or training. So we published further secondary study from the AFIRST data was to actually publish the clinician gestalt. How good are the clinicians? And reassuringly, 98.8% of the clinicians predicted 98.8% of all traumatic brain injuries. So very, very sensitive from that point of view. A couple of other studies that have been published from the AFIRST data. We published last year in paediatrics a study about vomiting in head injury. That's always been a bit controversial. That child's vomiting, we must scan them. So we looked at the risk of traumatic brain injury in children who present with vomiting. And what we showed was that vomiting is a common symptom in minor head injury. The incidence of traumatic brain injury in a child who doesn't have other symptoms apart from the vomiting is infrequent. And the ones that you worry about might have a traumatic brain injury are ones where you can find signs of a potential for a skull fracture, altered conscious state, altered behaviour in a child who's less than 2, according to the parents, or the presence of ongoing headache. There's a study that's just about to come out in Annals of Emergency Medicine, it's been online for a little while, about delayed presentations, children who have come to hospital more than 24 hours after their head injury. And in these children, we determined that they had a CT rate of 21.7% versus an 8.6% of the children who came to hospital less than 24 hours. So quite concerning increase in that CT rate. And what we showed was that the children who were more at risk of traumatic brain injury who came to hospital after 24 hours were likely to be associated with a suspicion of a depressed skull fracture or a non-frontal hematoma. So now, as a research network, we've done a lot of generation of data, and now we've recognised that we actually need to make this big step forward into knowledge translation. So with our experience around bronchiolitis, we undertook the task of writing the Australasian Bronchiolitis Guideline. That involved bringing together a large group of experts in the management of acute bronchiolitis and reading an awful lot of research papers and then determining a set guideline which has been endorsed by both the Paediatric College and the Emergency Medicine College and a number of important paediatric societies, and was being rolled out in 2018. So that went out to everywhere. This is the way you should be managing guidelines. And this is when we realised that that there is this huge gap, which Stuart has mentioned, 17 years, of where you can actually get good at research, you can produce great guidelines, and yet it doesn't get incorporated into practice. So we thought, well, we better look into this, and so now we're doing some quite a lot of work in the knowledge translation area. We've recently finished a cluster randomised trial of 26 sites where we've rolled out the Australasian guideline on bronchiolitis, and now we're looking to see which techniques are actually the most effective at actually incorporating those changes in practice in a sustainable manner into those hospitals. The nice thing about this is the first time we've actually included regional, metropolitan and a large number of emergency departments and paediatric hospitals across both our countries. So having had a taste for incorporating more emergency departments into our network, we've now also undertaken some further work in head injury, and we've undertaken the GAP study, where we're looking at what is the different managements in a regional rural centre versus a metropolitan centre versus the tertiary centres. So that study has just completed. The paper hasn't been published as yet, but in the 30 hospitals across Australia and New Zealand, what we've able to be demonstrated is there's actually not that much difference in the way we're actually CTing or even the length of stay in the patients who are coming to all of those different centres. There's slight variation, but nothing significant. I'm just going to move forward now and look at some of the studies we're about to start or we've got in planning. The exciting study that we've got with the PERC network from Canada is a study on preventing admission to bronchiolitis, so another bronchiolitis study. This is another interventional randomised control study. It's including 6 centres in Australia and New Zealand and another 12 centres in Canada, and we're administering dexamethasone plus adrenaline nebulizers to children as they present in ED and repeating that and comparing it to a placebo. And what we're hoping to be able to demonstrate is that we can reduce admission to hospital, which will have a significant economic effect and better for the families. We're also about to start we're in the planning for a study on, cute kid. A study on the management of neck injuries. That's a huge number of patients that come through our door, and we'll hear a little bit more about that in the predict session later on. we're going to derive and validate a prospective observational study on children presenting with neck injury so that we can actually come up with some paediatric relevant clinical decision rules. That's going to be bigger than AFIRS, so we're doing a lot of planning around that. Stuart mentioned a couple of the some of the collaborative studies that have been done with the PERN network. We are involved actively in the pneumonia study at the present time, and we're planning for a study into TXA as well, which will probably start next year. We haven't lost our enthusiasm for writing guidelines. We've just started. Well, we're in the middle of preparing all the papers for the head injury guideline that we're going to roll out as again as a binational guideline for management of head injury within the ED. And we'll undertake a revision of the bronchiolitis guideline probably in the next 12 months. So we want to make sure that our guidelines are reactive and relevant on an ongoing basis. So in planning, there's a few more things that are probably a little bit further away, but we are looking at severe asthma. Again, this is going to need to be across the world that we're going to undertake, looking at how do we manage the very few children who actually have severe asthma and what is the best therapy for those children. The problem we have is that we actually don't have any consistency around determining our outcomes. So we first have to work out what outcomes we're going to look at before we actually start doing an interventional study on that. We are very interested and are preparing some protocols on the management of sepsis, particularly looking at fluids and inotropes, and that's going to be a very important study. And we're rolling out an intubation registry shortly, and once we start doing that, we'll generate some data around the management of airways in the emergency department, which I think will be very interesting. One of the most exciting areas I think we've got into in the last probably 18 months or so has been really changing our focus into inclusion of our consumers in how what we're going to research, how we're going to do it, and making sure that they're actually reviewing all parts of our research program. We've developed, we've got 3 states that have got active ED consumer groups, and we're getting more and more sophisticated with the way we're incorporating them into our research planning. And it's a very exciting and I think very important area because we're actually making it pertinent to the people who are actually experiencing our care. So when I look at the goals that we set in 2004, I think we've been quite successful in developing infrastructure. We've been able to do multi-centre studies and publish them. We've been able to obtain funding for most of those studies. And I think really the thing I'm most proud about is that we've actually been able to grow out from our tertiary little ivory towers into the other emergency departments and actually be inclusive, and that way we're actually making sure that the care that we're looking at is being delivered in a much wider stage. So this is what Predict looks like now. We've expanded ourselves pretty much around, you have to understand Australia, everyone lives around the coast, so we've actually expanded ourselves pretty happily, and we've got good interaction with in most of the areas in New Zealand as well. And that's all I would like to say, and thank you very much for your attention.
Thank you, that was fantastic. I particularly love that we're actually getting research into translation, which is a difficult and relatively new area to be studying. Yeah. So I think that's great. I know we've got some questions from Twitter, so I'll throw it over to Edward.
Yep. So Dan Magnus, thanks for your question, saying we talk about networks like Predict for preventing us from reinventing the wheel, but we've also been hearing this morning about repeating studies in different settings and different countries, and what can we do to prevent the need for that repetition of research, or and also what do we do about the difference in how that research finding is then applied in different places so that there's a disparity despite the evidence showing one thing gets applied in 10 different ways?
Yeah, it's my question. I actually thought that when Stuart mentioned that. How do we sort of justify that? I think it is hard to really know when we should repeat studies and when we should just say, yep, that study's there and now we need to move on. We always need to value add to any research that we do. So we don't want to stagnate and just say, well, that research was the only thing that was correct. So although we will be repeating some of the studies, we will be adding in other outcomes or better things that are actually more relevant maybe from 10 years ago to what we're doing now in our practice. So I think it is value adding when we are repeating studies or seeming to be repeating studies.
I think the other thing is it's really important to realise that in meta-analysis there are a number of conditions where you look at it. So if you look at that probiotic research, if you looked at the meta-analyses of probiotics prior to that paper being done, it showed that probiotics would buy you a day of less symptoms. And that's really clinically meaningful for the families. Yet they then did 2 large definitive studies, one in the US and the one in Canada that I presented, which then showed that there's no difference in that. And that actually changes the landscape. So some of the trials that are being repeated, we're repeating smaller powered studies where we at times need to do definitive studies to truly answer the research question. So I think that's why we get some of the repetition that we hear about.
Another question here from Seb Gray. By the way, all of these are paraphrased for various reasons. So Seb is fascinated to hear about the planned research with adrenaline and dexamethasone in bronchiolitis, and I think is probably voicing what a lot of people have thought, which is why? Since we're also hearing that the evidence all suggests that nothing works in bronchiolitis, what was the reason for thinking that that combination of treatments would be effective and should be researched?
I actually think you should answer that.
I'm going to answer that as well. Look, the reason that came about is that the Perkin Network in Canada did a randomised control trial of 800 kids. It was a factorial design study. So you either got adrenaline or no adrenaline, and you got dex or no dex, and there were 4 groups. And the way you do factorial studies is that you're essentially trying to be efficient. You're essentially trying to answer 2 questions with 1 population. And so you're meant to just say, does adrenaline work? Yes or no. Does dexamethasone work? Yes or no. And they answered the question for no for both those things. And the ability to do it is that there should be no synergy between the 2 agents. Unfortunately for the Canadians, there was synergy between those 2 agents. And there's really good evidence in animal models to say that if you give both drugs together, it increases your mRNA production of various inflammatory markers. And that's why you get synergy with both those agents. So now we have to do the definitive study to answer that question.
Thanks very much. And the final thing is just to mention that the PEC Africa group, for you, Stuart, has got involved in the conversation after what you were mentioning about the global disparity. They've signposted us all to a rewrite of the original Lancet paper and have included a link. So I've retweeted that for anybody at the conference who wants to see it. It's nice that people in Africa are getting involved in the discussion.
Through live stream? That is great.
Yeah, hello.
That's fantastic. Any questions from the floor or from Africa? Keep tweeting. No? All right, well, we'll move on to Damien.